Good morning, everybody, and welcome. Today is November 2nd, 2021, and I'm pleased to call our ACIP meeting to order. I'm actually going to turn it over to Dr. Melinda Wharton to run through our announcements for the morning.
Good morning and welcome to the November 2nd and 3rd virtual ACIP meeting. Copies of the slides being presented at today's meeting are available on the ACIP website. Additionally, slides are available through a share file link for ACIP voting, liaison, and ex officio members. A few notes on meeting logistics for those who are listening in on the Zoom line. Please mute your lines at all times until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please virtually raise your hand. During the discussion period, Dr. Lee will take questions first from voting ACIP members and then from ex officio members and liaison representatives. Please disable your video. A profile picture is fine, just no live video. ACIP voting would ask ACIP voting members to turn their video on during the votes. The Advisory Committee on Immunization Practices is, at its heart, a public body. Next slide, please. Engagement with the public and transparency in our processes is vital to the committee's work. For this meeting, we'll be holding 2 oral public comment periods. The first oral public comment will occur today at approximately 12:10 Eastern Time. The second oral public comment period will occur tomorrow at approximately 3:45 Eastern Time. To create a fairer and more efficient process for requesting to make an oral comment, people interested in making an oral comment are requested to submit a request online in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2021-0112. Information on the written public comment process, including as well as information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains on all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflict of interest. I will now turn things over to Dr. Lee for roll call.
Thank you. Before we get started, I would like to let you know that Dr. Rochelle Walensky, the director of the CDC, has asked to join us and would like to make a few brief comments to the committee. So we are working to get her video on so that we can hear her speak.
Wonderful. Good morning, and thank you, Drs. Lee and Wharton, for giving me the opportunity to speak with you once again today. Today is a monumental day in the course of this pandemic, and one that many of us have been very eager to see. Ever since your vote on December 12th last year, recommending COVID-19 vaccination for those 16 and older, we have been asking when we will be able to expand this protection to our younger children. In the nearly 12 months that have passed since that vote, we have learned a tremendous amount, both about COVID-19 disease and the vaccines that combat it. And today, you have the opportunity to review those data, discuss the benefits of expanded vaccination, consider the risks, and make a recommendation that is likely to have tremendous impact. As you review the data today, it will be key to keep in mind the specific risks to children from this virus and this pandemic. and to put that risk into context of other vaccine-preventable diseases. Let's take varicella. In the 5 years prior to recommendation of varicella vaccination for children, each year there were somewhere between 4 and 31 hospitalizations per 100,000 children less than 20 years old. In those 5 years, 16 children aged 5 to 9 died from the virus. As you are all aware, in this most recent Delta wave, we saw pediatric admissions peak higher than they had in any previous wave of the pandemic, reaching a rate of 25 hospitalizations per 100,000 per year in children between the ages of 5 to 11. And there have been 745 deaths in children less than 18 and 94 deaths in children aged 5 to 11 since the start of this pandemic. Yes, fortunately, these most severe outcomes are generally rare. The chance that a child will have severe COVID, require hospitalization, or develop a long-term complication like MIS-C remains low. But still, the risk is too high and too devastating to our children, and far higher than for many other diseases for which we vaccinate children. There are now over 5,200 children diagnosed with MIS-C and living with the complications of that disease. We also know that beyond the clinical impact of COVID on children, there have been detrimental social and mental health impacts that we are just beginning to fully understand. For almost 2 full years, school has been fundamentally changed. There are children in second grade who have never experienced a normal school year. There are students in middle school who missed out on school sports and extracurricular activities. There are missed proms and homecoming dances and too many missed graduations. We have watched as the education gaps that exist in this country have widened as this virus has disproportionately impacted racial and ethnic minority communities. Pediatric vaccination has the power to help us change all of that and to let us move towards schools as we once knew it and hope it can be, a safe and enriching environment for all of our children. I also think that I share with you a perspective that pediatric vaccination is just one important piece to this puzzle. It is important that we also continue to vaccinate as many adults as possible to provide protection to children in the community, including those younger than 5 who may not be eligible yet for vaccination. Looking at data from August through October of this year, as we saw Delta cases increasing sharply across the country, there were stark differences in pediatric cases based on community vaccination level. In a stepwise fashion, as the percent of eligible population fully vaccinated increased, the number of pediatric hospitalizations decreased. It is our ongoing responsibility to make sure as many people as possible are vaccinated and protected from COVID-19. I know that you have much to discuss today, and I look forward to listening to your deliberations. As always, I am most interested in hearing how you interpret what we know and acknowledge areas of uncertainty. I greatly appreciate your dedication to getting this right and to making sure that we continue to move forward in our efforts to end this pandemic with science leading the charge. Thank you for giving me the opportunity to speak with you this morning, and thank you for all you are doing for all of us. With that, I'll turn things back over to Dr. Lee. Thank you.
Thank you very much, Dr. Walensky, for addressing the committee this morning. Our advisory committee very much appreciates your engagement in our work, and we look forward to providing the advice and guidance that you need to support decision-making for the country. So we will begin our meeting with roll call, starting with ACIP members and then ex officio members and liaisons. And as a reminder, I'll ask that you state your name, affiliation, and whether you have any conflicts of interest for the ACIP members. And today we will start with Ms. Bata.
Good morning. This is Lynn Bata. I'm the immunization clinical consultant at the Minnesota Department of Health, and I have no conflicts.
Thank you and good morning. Dr. Bell.
That's Bell, clinical professor, University of Washington School of Public Health. No conflicts.
Thank you. Dr. Brooks.
Oliver Brooks, Chief Medical Officer at Watts Healthcare Corporation. Good morning, and no conflicts.
Good morning, and thank you. Dr. Chen.
Good morning. Wilbur Chen. I'm a professor of medicine, and I'm an adult infectious disease physician scientist at the University of Maryland School of Medicine. My employer, the University of Maryland, Baltimore, has a grant from Emergent Biosolutions that supports the work that I do on developing a Shigella vaccine. No other conflicts.
Thank you, Dr. Chen. Dr. Saneas.
Dr. Sybil Saneas. I am an internist and a pediatrician. I'm an associate professor of medicine and pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you, Dr. Daly.
Good morning. I'm Matt Daly. I'm a senior investigator at Kaiser Permanente, Colorado. I'm also an associate professor of pediatrics at the University of Colorado School of Medicine, and I have no conflicts.
Thank you. Dr. Cotton?
Good morning. Camille Cotton. I'm the clinical director of transplant and immunocompromised host infectious disease at Massachusetts General Hospital and associate professor at Harvard Medical School. I have no conflicts.
Thank you. Dr. Lair?
Dr. Jamie Lair. I'm a private physician in family medicine in Ithaca, New York, taking care of both adults and children, and I have no conflicts of interest.
Thank you. Dr. Long?
Good morning. This is Sarah Long. I'm a pediatric infectious disease doctor and professor of pediatrics at Drexel University College of Medicine. I have no conflict.
Thank you. Ms. McNally?
Good morning. Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Paling?
Good morning. This is Kathy Paling. I am professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflict. Thank you.
Thank you, and good morning. Dr. Sanchez?
Good morning, Pablo Sanchez. I'm a professor of pediatrics at Ohio State University College of Medicine, and I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's in Columbus, and I have no conflict. Thank you.
Thank you. Dr. Talbot?
Good morning. I am Kip Talbot. I'm an associate professor at Vanderbilt University Medical Center, where I am an adult infectious disease doctor, and I have no conflicts of interest.
Thank you. Dr. Alt is unable to attend today, and I am Grace Lee, professor of pediatrics at Stanford University School of Medicine, associate chief medical officer at Stanford Children's Health, and I have no conflicts. Next, we'll move on to our ex officio and liaison members. And as a reminder, I will announce the organization name, and please indicate who you are and if you're present in your first and your last name. So with our ex officio representatives, we will go to the Centers for Disease Control and Prevention first.
Good morning. Sam Posner, Acting Director, NCIRD, present.
Thank you. Center for Medicare and Medicaid Services.
Good morning. Mary Beth Hance, representing CMS, present.
Thank you. Food and Drug Administration.
Good morning. Doran Fink, representing the U.S. Food and Drug Administration, Office of Vaccines, present.
Thank you. Health Resources and Services Administration.
Good morning. This is Mary Rubin from the Division of Injury Compensation Programs, HRSA, present.
Thank you. Indian Health Service. Sorry, I'm not sure if I was muted. Indian Health Service. We'll move on to National Institutes of Health.
Morning, John Weigel, National Institute of Allergy and Infectious Disease, NIH.
Thank you. Good morning. Office of Infectious Disease and HIV/AIDS Policy.
Good morning. This is David Kim, representing OIDP. Thank you.
Thank you, Dr. Kim. We'll move on to our liaison representatives. First, American Academy of Family Physicians.
Good morning, Pamela Rockwell, liaison to the American Academy of Family Physicians. I'm a professor of family medicine at the University of Michigan Medical School. Thanks.
Thank you. American Academy of Pediatrics.
Good morning. Bonnie Maldonado, professor of global health and infectious diseases, Stanford University School of Medicine, and chair of the Committee on Infectious Diseases for the American Academy of Pediatrics.
Thank you. American Academy of Pediatrics Red Book.
David Kimberlin, Professor of Pediatrics at the University of Alabama at Birmingham and editor of the AAP Red Book.
Thank you. American Academy of Physician Assistants.
Good morning. Marie-Michelle Léger, Director of Clinical Education, representing AAPA.
Thank you. American College Health Association.
Morning, Tavi Chai, and with my co-liaison, Sharon McMullen, present. Thank you.
Morning, and thank you. American College of Nurse Midwives.
Carol Hayes, present.
Thank you, Ms. Hayes. American College of Obstetricians and Gynecologists. We'll move on to the American College of Physicians.
Good morning, Jason Goldman, General Internal Medicine in Coral Springs, Florida, also affiliate associate professor at Florida Atlantic University. Pleasure to be here representing the American College of Physicians.
Thank you. American Geriatric Society. American Health Insurance Plans.
This is Bob Gluckman representing AHIP, present.
Thank you. American Immunization Registry Association.
Good morning, Rebecca Quayle representing ERA.
Good morning. American Medical Association.
Sandra Freihofer, practicing general internist in Atlanta, adjunct associate professor of medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Good morning, Chad Riddle representing the ANA.
Thank you. American Osteopathic Association.
Good morning, Stan Grog, present.
Good morning. American Pharmacists Association.
Good morning, Michael Hogue, Dean and Professor of the School of Pharmacy and Professor of Preventive Medicine in the School of Medicine at Loma Linda University in California, representing the American Pharmacists Association.
Thank you. Association of Immunization Managers.
Hi, this is Molly Howell, Immunization Director for the North Dakota Department of Health, representing AIM.
Thank you. Association for Prevention, Teaching, and Research.
Richard Zimmerman, University of Pittsburgh, representing the association and present. Thank you.
Thank you. Association for State and Territorial Health Officials.
Morning, Dr. Lee. This is Nirav Shah. I'm the Director of the State of Maine Center for Disease Control and Prevention and the President of ASTO. Thank you.
Thank you. Biotechnology Innovation Organization.
Good morning. Phyllis Arthur representing Bio.
Good morning. Thank you. Council of State and Territorial Epidemiologists.
Yeah, Dr. Christine Hahn representing CSPE.
Thank you. Canadian National Advisory Committee on Immunization.
Good morning, Shelley Deeks, Chair of Canadian NACI.
Good morning, Dr. Deeks, and welcome. Infectious Disease Society of America.
Good morning. This is Jeff Duchin. I'm the Health Officer of Public Health, Seattle and King County, Professor in Medicine in the Infectious Disease Division, the University of Washington, and Professor at the School of Health, Public Health, University of Washington, representing the Infectious Disease Society of America.
Thank you. International Society for Travel and Medicine.
Elizabeth Barnett for ISPM, present.
Thank you. National Association of County and City Health Officials.
Good morning. This is Matt Zahn representing NACHO, present.
Thank you. National Association of Pediatric Nurse Practitioners.
Good morning. Patsy Stinchfield representing NABNAP.
Good morning. National Foundation for Infectious Diseases.
Good morning. This is Bill Schaffner, Professor of Preventive Medicine and Infectious Diseases at Vanderbilt and Medical Director of the NFIB.
Good morning and thank you. National Medical Association.
Good morning. Virginia Kane, Director and Chief Medical Officer for the Health Department in Indianapolis and Associate Professor of Medicine in the Division of Infectious Diseases at Indiana University School of Medicine, and no conflict.
Thank you. Pediatric Infectious Disease Society.
Good morning. Sean O'Leary representing PID.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good morning. Corey Robertson, present.
Thank you. Society for Adolescent Health and Medicine.
Hi, good morning. It's Amy Middleman representing SAM.
Morning. Society for Healthcare Epidemiology of America.
Good morning. Marcy Dries, Chief Infection Prevention Officer at Christiana Care, representing SHEA.
Wonderful. And I'll just ask if there are any liaison organizations or individuals who joined after roll call.
Good morning, Dr. Lee. This is Dr. Matthew Clark, representing the Indian Health Service.
Thank you, Dr. Clark, and welcome. Okay. So with roll call now complete, we'll move on to the first session for the morning. During today's meeting, I will invite individuals to contribute to the discussion as always. Please raise your hands electronically, and I will call on ACIP members first, followed by our ex officio members and liaisons. If you wish to respond to a particular comment or question, please try and indicate this electronically. And Dr. Matt Daly, chair of the COVID-19 Vaccines Work Group, will provide an introduction and an overview of today's meeting. Dr. Daly, the floor is yours.
Well, thank you so much. So I'm going to introduce today's session on behalf of the ACIP COVID-19 Vaccines Work Group. Next slide, please. So this is a graph that we have seen before. This presents the daily trends and number of COVID-19 cases in the United States for all ages from January of 2020 through October 28th of 2021. And as you can see, we're in the middle of a second wave, which is only exceeded by the wave we experienced in December of 2020. And there have been, in the United States, almost 46 million cases of COVID-19 that have been reported. Next slide, please. So to introduce the topic of burden of COVID-19 in children 5 to 11 years of age, just a couple points I wanted to highlight here. There have been 1.9 million cases reported in children of this age. In addition, there have been more than 8,000 hospitalizations, again, in this age group, and 2,316 cases of multisystem inflammatory syndrome in children, or MIS-C, and 94 deaths reported in children 5 to 11 years of age in the United States. It's also important to highlight the fact that the burden of COVID-19 in children in this age group extends well beyond these case counts. Just to mention a few factors, including school being tremendously interrupted and lives entirely disrupted. Next slide, please. So to describe the COVID-19 work group activities for the month of October 2021, the work group has been reviewing data regarding pediatric COVID-19 vaccines. This has included reviewing data on SARS-CoV-2 seropositivity in children, a detailed review of pediatric COVID-19 epidemiology. In addition, the work group has heard from Scenario Hub regarding modeling the results of impact of pediatric vaccination on the pandemic. In addition, we've had the opportunity to review the results of the Pfizer-BioNTech clinical trial in children 5 to 11 years old. We have reviewed the grading of the scientific evidence regarding vaccination in this age group. And then we've had detailed discussion regarding the evidence to recommendations framework for the decision before us today. Next slide, please. So, as folks are well aware, the Food and Drug Administration expanded emergency use authorization, or EUA, regarding Pfizer-BioNTech COVID-19 vaccine to include children 5 through 11 years of age. To highlight a couple of features of this, the pediatric formulation is a 10 microgram dose given intramuscularly, administered as a 2-dose series, 3 weeks apart. And we're going to hear much more about the evidence today, but to highlight a few points, in 5 to 11-year-olds, there were 4,600 participants in a clinical trial, and this was randomized 2-to-1, so 3,100 roughly received vaccine and 1,538 received placebo. In addition, we have the knowledge and experience gained by vaccinating more than 247 million individuals 12 years of age and older in the United States with Pfizer-BioNTech in the 30 microgram formulation in the United States. And as those listening are well aware, this vaccine was fully licensed in people 16 years of age and older in August of 2021. and this licensure was based on longer-term follow-up data. Next slide, please. So here's the agenda for today. First, we'll hear a presentation by Dr. Gertman from Pfizer regarding Pfizer-BioNTech BNT162b2 use in children 5 to 11 years of age. Following Dr. Gertman's presentation, we'll have a break, and this will be followed by public comment. After the public comment, we'll hear a presentation from Dr. Jones at the CDC regarding SARS.
Dr. Daly, I think your microphone cut out. I'm just going to finish up for Dr. Daly. He's logging back in, but he was just going through the events for today. I believe we were at SARS-CoV-2 epidemiology in children by Dr. Jones. Dr. Matt Oster from CDC will discuss myocarditis in adolescents and young adults. Dr. Tom Shimabukuro will provide an overview of vaccine safety surveillance in children. Dr. Chatham Stevens will discuss implementation of COVID-19 vaccines pediatric program. After the break, we will then come back and return to Dr. Woodworth to discuss clinical considerations. And Dr. Oliver, as always, will take us through the evidence to recommendations framework for pediatric COVID-19 vaccines, followed by a vote. And I anticipate we will have robust discussion after each of these sessions throughout the day. So we appreciate everyone's patience. And would just like to clarify to get us started that, the overall discussion for today will follow the FDA emergency use authorization regarding the question of should we recommend the Pfizer-BioNTech BNT162b2 use in children 5 to 11 years of age. And so we look forward to having that conversation with the committee members today. With that, I think I am ready to turn it over to Dr. Alejandra Gertman from Pfizer. Oh, I apologize. Our work group members. I just want to acknowledge the work of the work group. And, as many people have said in the past, we can't thank our CDC colleagues who have been leading this work throughout, the ACIP members and our liaison members and our expertise that is on the work group. It has been a very robust set of discussions that have led us to today. And it has been incredibly helpful for really focusing in on the data that's critical for decision making and making sure we have the information today we need as a committee to move forward. We can move to the next slide. And this extensive list of CDC participants, it really takes a village to be able to provide as much data as possible. It is clear that we always want more data and we always want perfect data, but we have the data we have today. We're very much looking forward to making sure we have a good understanding of what we need to move forward to make a decision. And I believe that is it. Next slide. Thank you. Okay, perfect. We'll move on to Dr. Alejandra Gertman from Pfizer to present on the Pfizer-BioNTech pediatric COVID-19 vaccines in kids 5 to 11 years of age. Dr. Gertman?
Good morning, and thank you, Dr. Lee and the ACIP committee for the opportunity to present today. My name is Alejandra Gertman, and I am in the Vaccine Clinical Research and Development Group at Pfizer. I am really pleased to present to you today the Pfizer-BioNTech clinical data that has received emergency use authorization in individuals 5 to less than 12 years of age. Next slide, please. I will focus primarily on the clinical data that demonstrates clear and compelling vaccine safety and efficacy that supported the EUA in this age group. Next slide, please. Pfizer-BioNTech received emergency use authorization of a 10 microgram dose of the vaccine for use in children 5 to less than 12 years of age. A lower dose of 10 micrograms was selected as the optimum dose for this age group based on favorable reactogenicity profile and robust immunogenicity results from a dose finding and a phase 2/3 study. The indication is for the active immunization to prevent COVID-19 caused by SARS coronavirus 2 in individuals 5 to less than 12 years of age, administered as a primary series of 2 doses of 0.2 ml each, 3 weeks apart. Next slide, please. I will share information with you today that the vaccine met EUA guidance for children 5 to less than 12. You will see that the vaccine met all safety data expectations as well as immunobridging criteria. 90.7% efficacy was observed. Plans are established for active follow-up of safety under the EUA, and the vaccine benefits outweigh these risks. Next slide, please, which is brief. I will now share with you the clinical data, and we can go to the next. We will begin by looking at the experimental design of the vaccine study. This began with a phase 1 to identify a preferred dose level based on immune response and a safety profile. The 10 microgram dose, 1/3 of the adult dose, was chosen because it had the right balance between immune response and satisfactory reactogenicity profile. This 10 microgram dose was advanced into a phase 2/3 with a randomization scheme of 2-to-1. Please keep this in mind when we're looking at both the safety and efficacy later. The first group of safety information includes approximately 1,500 individuals that received the vaccine versus 750 that received placebo. At the request of the FDA, we also enrolled approximately 1,500 additional individuals who received vaccine and 750 placebo recipients, most of whom have at least 2 weeks of safety data after those 2. Non-inferior immune responses have been established comparing responses in children 5 to less than 12 to individuals 16 to 25-year-olds from the pivotal phase 3 study. Although not required for emergency use authorization, COVID-19 surveillance was conducted permitting evaluation of vaccine efficacy. Next slide, please. This represents a phase 2/3 timeline of participants in this age group. This scheme is similar to the scheme for other populations in which the doses are administered 21 days apart. Reactogenicity data was captured for 7 days, non-serious adverse events were captured for a month, and serious adverse events were captured for 6 months. To enhance possible detection of the rare event of myocarditis observed in adolescents and young adults, should it occur, specific instructions were provided to investigators to be vigilant for symptoms and signs of this condition, including chest pain, and to perform workup in the event of suspected myocarditis. Blood draws were obtained as shown to measure immune response, and as for nearly all our trials, we continue to obtain surveillance on the population to look for the potential to demonstrate efficacy, and this proved possible in this trial as well. On the next slide, please. This represents the 2 data sets that have been submitted to support the emergency use authorization. One is the initial cohort of 2,268 participants for which the median follow-up time is 2.3 months, which is shown at the top on the blue bar. In the latest submission, follow-up of this group has been extended as shown in the light blue. However, I will not discuss further this piece in this presentation. Additionally, as I mentioned before, and represented now in the slide by the lower bar graph, we also enrolled an additional cohort of 2,379 participants. In conjunction with the original cohort, this permits evaluation of a total of approximately 3,000 vaccine recipients to define rare events for at least 2 weeks for most of the 3,000 vaccine recipients, and for 2 to 3 months for over 1,500 vaccine recipients in the submission done to the FDA. I will describe safety in the initial safety enrollment group first. In the next slide, please. Here are the demographics for those aged 5 to less than 12 in the initial enrolled safety population. Demographics for the additional safety group and efficacy population are similar. You can see that there was good representation in terms of gender, race, and ethnicity. The mean age of vaccination was in the middle of the age span between 5 to 11 at 8 years of age. More than 11% of the population had obesity as an underlying condition, and comorbidities, including obesity, were represented in approximately 20% of the population. Next slide, please. Shown here are local reactions by maximum severity within 7 days after each dose. Dose 1 is at the top, and dose 2 is at the bottom. You can see the reactions in the 5 to less than 12 age group compared to the 16 to 25. There is some increase in mild to moderate redness and swelling, both after dose 1 and dose 2 in the 5 to less than 12 age group. Pain and injection site was comparable between the 2 age groups. And in general, the local reactions meet a satisfactory safety profile. Next slide, please. Systemic events are shown in this slide by maximum severity within 7 days after dose 2 in children 5 to less than 12 compared to the 16 to 25-year-olds. Reactions were typically higher in vaccine recipients. Dose 1 reactions tended to be less frequent and are not shown in this presentation. The vaccine group is shown at the top of the graph and the placebo group at the bottom. I would like to draw your attention particularly to fever and chills. You can see that, if anything, the incidence of fever was lower and mostly mild to moderate in individuals who were 5 to less than 12 compared to the older age group. And this was true for chills, and likewise, across the other systemic event parameters, you can see that responses were comparable or less to those seen in the 16 to 25-year-olds, again representing a satisfactory systemic reaction profile for 5 to less than 12-year-old children. Next slide, please. Now I am showing you local reactions by maximum severity within 7 days after each dose by baseline SARS-CoV-2 status. Again, dose 1 is at the top and dose 2 is at the bottom. You can see that local reaction rates were very similar regardless of baseline status, with a slight increase after dose 1 in participants who are SARS-CoV-2 positive at baseline, which is similar to what we have seen in the adult pivotal study. And in the next slide, please. When looking at systemic events by maximum severity within 7 days after both doses, you can see that there are almost no differences between the two doses regardless of the baseline SARS-CoV-2 status. I will now, if you go please to the next slide, we'll review the unsolicited adverse events. And next again. Thank you. This graphic represents overall adverse events from dose 1. The initial enrollment group is shown at the top, and the safety expansion group is shown at the bottom. In both groups, you can see comparable levels of any adverse events or related adverse events. There were very few serious adverse events and no related SAEs and no deaths. One female participant was withdrawn from the study due to a fever of 40 degrees centigrade on day 2 after the first dose, accompanied by neutropenia. The fever resolved in 1 day. This child carries a pre-existing diagnosis of benign neutropenia, and she's been followed by a hematologist, and she recovered uneventfully. Next slide, please. This now represents adverse events occurring at an instance of greater than 1% by system organ class for this age population in the initial enrollment group. You can see comparable rates between vaccine recipients and placebo recipients, whether we're talking about any adverse event or any of the categories specified underneath. This again reflects a satisfactory safety profile in events common to this age group. Lymphadenopathy has been infrequently observed in other populations after vaccine, and it was observed in 0.9% of vaccine recipients in this enrollment group. Next slide, please. This now represents comparable analysis of adverse events, but now I'm showing you the safety expansion enrollment group. And you can see that the rates are very similar between vaccine and placebo as in the initial group. And again, in our opinion, representing a satisfactory safety profile. Next slide, please. And if we want to look at the rates of adverse events from dose 1 to 1 month after the second dose by baseline SARS-CoV-2 status, you can see that the rates are very similar or a little lower in those who are positive compared to those who are negative prior to vaccination. Next slide. Serious adverse events from dose 1 to the cutoff day are shown here for both safety groups. All SAEs were considered unrelated. 3 events are related to trauma and 1 related to the ingestion of a foreign body. In the expansion safety group, 1 participant reported infective arthritis of undisclosed etiology 15 days after dose 1. It resolved 21 days later. Next slide, please. We follow participants for adverse events of special interest as designated by either the FDA or the CDC. Summaries for both enrollment groups are shown here. For FDA adverse events of special interest, no anaphylaxis, no myocarditis, no Bell's palsy, and no appendicitis were reported. For the CDC adverse events of special interest, angioedema and hypersensitivity were uncommonly observed in both vaccine and placebo recipients, and they were short-lived. Rashes tended to be more common after vaccine, but in general, they were uncommon. Overall, they were mild and short-lived as well. The one case of arthritis is the infective arthritis I already described to you. And there is a case of vasculitis, which was reported as a mild case of henoch-shonine purpura, considered unrelated to vaccine, that occurred 21 days after dose 1, and follow-up of this child is ongoing. In the next slide, I will want to show you the safety conclusions for the 5 to less than 12 years old. Reactogenicity was mostly mild to moderate and short-lived. Observed mild to moderate local reactions, redness, and swelling, which were captured by the e-diary, were more common, and systemic reactions, including fever, were less common than those in the 16 to 25-year-olds. The observed adverse event profile in the study did not suggest any safety concerns for BNT162b2 vaccination in children 5 to less than 12. The database of approximately 3,000 enrolled active vaccine recipients provides a high degree of confidence for the following rare events proximate to vaccination, such as myocarditis or anaphylaxis, and are unlikely to occur at the rate of 1 in 1,000 or higher. In the next slide, I would like to turn now to the examination of the immune response to the vaccine. Next slide, please. Immunobridging criteria comparing the 5 to less than 12-year-olds to the 16 to 25 were met, both for the geometric mean ratio and for the sero response as shown on this slide. SARS coronavirus 2 neutralizing antibody titer is represented at the top. You can see the geometric mean titers represented after the second dose in the middle 2 columns in blue. The geometric mean ratio of 1.04 is shown on the right-hand side, with the lower bound of the confidence interval well above the 0.67 criterion. The observed GMR was above the pre-specified criteria of 0.8 and also above the GMR of 1.0 requested post-hoc by the FDA. In addition, seroresponse rates are shown at the bottom. You can see the seroresponse rates were virtually identical in the 5 to less than 12 age group compared to the 16 to 25 at 99.2% apiece. And this criterion was also made with a lower confidence bound value of -2%, well above the -10 that was required. In the next slide, please. Shown here are the GMTs by baseline SARS-CoV-2 status. You can appreciate that titers are higher in those who are positive at baseline, which is shown in the middle panel in green, compared to those who are negative on the right. Please keep in mind that the number of positive participants in this subset is relatively small. And in the next slide, when looking at GMTs by age subgroup, you can see that titers are virtually identical across all ages, whether 5 to 6, 7 to 8, or 9 to 11. Next slide. It was also important and requested by the FDA for us to look at the response to the Delta variant, given its prominence as the cause of COVID-19. As we have seen in older populations, the responses were quite robust, not only to the wild type shown on the left-hand side, but also to the Delta variant on the right. This is done in the subpopulation of 34 individuals that were studied. Please note the comparable post-vaccination titers at 1 month for the wild-type vaccine strain and for the Delta variant, with high geometric fold rises shown at the top. This comparable response predicts efficacy for the 5 to less than 12 age group during a time when the Delta variant is prominent. And in the next slide, you will see that high efficacy against COVID-19 was in fact observed when examining COVID-19 occurrence from 7 days after dose 2. Remembering that the randomization in this study was a 2-to-1 vaccine versus placebo, the case split of 3:16 with surveillance time shown. It's an efficacy of 90.7 with a high degree of confidence shown as well. No severe cases of COVID-19 or multi-system inflammatory syndrome in children were reported in either group. Note that the cases occurred in July to September when the Delta variant was the most prominent variant in circulation. At this time, 14 of the 19 samples had been successfully sequenced and all yield the Delta variant, confirming high efficacy against this highly transmissible strain of SARS-CoV-2. In the next slide, I would like to show you the curve with cumulative incidence of all available COVID-19 cases beginning after dose 1. The mean length of follow-up time after dose 2 is 3.3 months. The placebo cases are in red, vaccine cases are in blue. Efficacy was durable for this period of follow-up to date, and surveillance is continuing. In the next slide, I would like to summarize the immunogenicity and efficacy conclusions. Immunobridging success criteria were met for 5 to less than 12 years old compared to the 16 to 25-year-olds group. The vaccine immune sera effectively neutralized both the wild-type vaccine virus as the highly transmissible Delta variant of concern. BNT162b2 as a 2-dose series demonstrated high efficacy against COVID-19 in this population of 5 to less than 12 when the Delta variant was prominent. Next slide, please. Pharmacovigilance activities are a critical component of activities to detect unexpected safety events rapidly. Pfizer continues to conduct robust pharmacovigilance activities and collaborate with regulators and international groups. Proactive risk mitigation activities such as labeling, educational materials, and biodifferentiation will continue. Pharmacoepidemiology studies will include children 5 years and up to evaluate for myocarditis occurrence and sequela, as well as other possible rare adverse events. This includes one study that will follow up identified U.S. post-vaccination myocarditis and pericarditis cases for 5 years within the Pediatric Heart Network. And in the next slide, I would like to conclude my presentation by acknowledging and thanking all those who made this possible. The clinical trial participants and their families foremost, the sites, investigators, the CRO, our partner and their staff, and the FDA for the guidance to help us assess and address these urgent medical needs. Thank you.
Thank you, Dr. Gertman. This session is now open for questions. I see Dr. Long's hand is raised. Dr. Long?
Yes, 2 clarifying questions. One is, what were the dates of the studies so that we can understand the prevalence of and which strains of the virus were circulating at the time? Maybe answer that, and then I have one follow-up question, if that's okay, Dr. Lee, about the same thing.
Of course.
Thank you, Dr. Long. The study, the phase 1 study, which was the dose finding, was initiated in March, but the phase 2/3, which is the data that I presented mainly today, the study was started at the end of June, and the cutoff day for the data that I showed with the cases was October. So it's really, and considering the 2 doses that we were given is mainly July to September is when we saw the cases.
Okay. So the second question is, I see that you said day 1, I assume, and you gave some neutralizing antibody geometric mean titers. And I saw that what I must understand then is pre-dose 1 titer of 10. And I am a little surprised about that, because if it were truly negative, wouldn't you have assumed a lower titer? So my question is, I know you did not try to enroll patients who had previously had coronavirus infection, but the question is, what percentage of patients had antibody prior to dose 1?
Thank you for the question. So the prevalence that we had in the study between the placebo and the active vaccine recipients was between 8.7 and 8.8. So we did allow for prior infection, and we also did, PCR swabbing and binding protein prior to the first vaccination to determine the seroprevalence, and the rate was about almost 9%.
Okay. And then when you calculated your vaccine efficacy, I didn't quite understand the title of the slide and the data. Did you, in that, only include those who were seronegative at first vaccine, or did that include the 9% who were seropositive?
Yeah, so the data that I show you is in those who were seronegative. However, we did look at both seronegative and seropositive, and the vaccine efficacy is virtually identical because there were no additional cases in the seropositive children.
Thanks very much.
Thank you. We'll move on to Dr. Paling.
Thank you, Dr. Gertman, for this presentation. And I also want to say thank you for making sure the enrollment included diversity. I think that's really important. My question for you is, I believe you showed us the immune response across age groups, and that was similar. My question is, did you look at the safety, local and systemic effects by age group as well? And what did you learn?
So thank you, Dr. Paling, for the question. We did look at both safety and immunogenicity by age groups, and as much as we didn't see almost any difference in immunogenicity, there were no differences in safety either.
Okay. And then the second question I have for you is I wanted to learn a little bit more about lymphadenopathy. That was, I believe, 0.9% of the original cohort. And can you share the characteristics of that lymphadenopathy, please?
I lost your voice. If I can share on the second cohort, is that the question?
Could you share the characteristics of the lymphadenopathy you saw in the trial, please?
Yes. So as I mentioned, in the initial cohort was 0.9%, and in the expansion safety cohort was 0.4%. The characteristics were, and I'm trying to pull one of my slides. If you just give me 1 second. So in the 0.9, 13 participants in this age group reported lymphadenopathy, and most of them were in the vaccine recipient group. 9 of them were deemed related by the investigators. The mean onset was 2.6 and 6.2 days for the first dose and for the second dose, and the duration was 4.7 days. And all of them were restored by the time of the initial safety data cutoff, which was September the 6th.
Dr. Gertman, which slide was that? Would you be able to, is it a slide we have that we could post?
Oh, no, sorry, this is in my backup slide for myself for notes.
Okay, thank you.
I'm happy to share after.
Thank you, Dr. Paling. Any additional questions?
I will turn the floor over to others.
Thank you. Dr. Sanchez.
Thank you, and thank you for that presentation. Certainly exciting results. A few questions. First of all, I'm interested in the ones who previously had, who had tested positive for SARS-CoV-2. I assume that none gave the history of having been positive because you were trying to enroll those who have not had COVID before, first of all. Is that correct?
Well, so in the phase 1 part of the study, we didn't allow for prior diagnosis of COVID-19. However, on the phase 2-3, we did allow for children to be enter into the study. So the majority of the 8.7 that I referred is actually either serology or PCR testing. But there were a number of children, not many, and I have to go back. Maybe I can ask if one of my Pfizer colleagues has that number. But there were less than 20 kids, I can tell you that with some certainty, that carry a diagnosis of prior COVID-19.
So that was not a definite exclusion?
No, it was not for the phase 2-3.
Okay. And then in your slide 24, when you look at the SARS-CoV-2 positive before and then geometric mean titers, there's actually quite an increase. I mean, it's really quite high after dose 2. Do you have data after dose 1? I guess my question is, if there's an amnestic response, that do all these kids need 2 doses, or do past ones, would they, and I know that there's few of them, but do you have data on the geometric titers after dose 1 to see if the amnestic response is as similar as those who were seronegative after the second dose?
So no, we don't have the data. We try to minimize the number of bleeds to ensure that kids, and their families wanting to be part of the study. And so we only have the baseline and the 1 month after dose 2. So I'm not able to answer that question from this particular study.
And then another question. So generally these were healthy, but some had some risk factors, which you mentioned the majority were obese. And did you have any immunocompromised patients at all?
So to answer the first part, about 11% of the children had a diagnosis or, by BMI of obesity, 20% overall comorbidities. The most common comorbidity after obesity was asthma, with about 8%. And by design of the study, we did not allow for children who carry a diagnosis of being immunocompromised to be allowed to be part of the study. However, we are conducting a study in immunocompromised children, which will expand the whole age group from 2 years of age all the way to 18. And depending on the age group, we will have, different doses according to what has been now either under the EUA. So hopefully we have that data in the future. And that study will include a third dose as a booster, but not in this one.
And among the obese patients, and I'm sorry, Dr. Lee, I hope that this is okay.
Go ahead, Dr. Sanchez. We want to make sure all your questions are answered.
And in terms of the obese patients, did you see any change in the geometric mean titers between the obese ones versus those who were normal, were not obese?
I may ask Dr. Gruber if he's online, if he remembers if we have done that analysis, because honestly, at this time, I don't remember.
Yeah, hi, this is Bill Gruber, the head of Vaccine Clinical Research and Development. And yes, we have looked at that. I think maybe John Perez may be on as well, and did not see a difference. I might just add that my recollection too is that in terms of looking at outcomes, we didn't have, as I recall, individuals that were obese in terms of cases in either group. But I think the 3 cases that we had in individuals with underlying disease, all of whom were in the placebo group, had asthma. But others can correct me if I'm wrong about that.
Well, that's correct, Bill. Thank you.
Okay, thank you.
And finally, and this has come up from a practical standpoint, did any of your patients turn 12 at the time of the second dose? And if they do, would you recommend that, or did you give them the usual dose, or any recommendations from your company and from your experience as to whether that dose should be increased if they reach, with the second dose they turn 12?
Yeah, so we did have children who turned 12. I believe that we have about 7 children. All of them received a second dose of 10 micrograms. So the study was designed knowing that this could happen and with the intention that the second dose will mimic, will be the same than the first. And in terms of recommendations for, what to do with this situation, I will leave that to maybe the ACIP committee to make recommendations. But we did have that.
Thank you, Dr. Gertman. Thank you, Dr. Sanchez. I just want to make sure I understood that. So those who were per protocol stayed on the 10 microgram dose, even if they changed age during the middle of the trial.
That's correct.
Okay, thank you. That's very helpful. Actually, while we're on this slide, I'm just going to make one quick comment, which is on slide 24. I actually think it's really helpful that the neutralizing titers were captured specifically on day one, because if you look at the SARS-CoV-2 positive patients, their titers are actually not that high, which I think is really helpful to us to understand that, boosting that immune response could be of a significant benefit to those children. And I'll also just highlight that a comment made earlier about age-specific sort of breakdown in terms of safety profile would similarly be helpful. If you go to slide 25, I really appreciated that you did this for immunogenicity. A parallel slide for safety, I think, would be really helpful for clinicians as well. We'll move on to Dr. Paling.
Hi. I wanted to follow up on a little bit of what we were just talking about. One of the questions that I have is, could you describe the level of obesity that was included in the trial?
Thank you for the question. We use the definitions for BMI. I am not able to describe further than that 11% actually met criteria according to BMI for this age group.
Okay. Yeah, I think, this is Bill, maybe just Bill Gruber again. I think it's actually at the bottom of the slide, slide 9, where BMI had to be greater than the 95th percentile, if I'm reading that right.
Okay. So that's how you defined it, but you didn't get into the grades of obesity, if I understand it correctly.
We didn't, no.
Okay. The other question I have is, on your slide showing the COVID positivity among people, the children who received the vaccine and those who received the placebo, were any of those children hospitalized?
No, we didn't have any hospitalization or severe disease in this age group.
Okay. And then the second question is, I believe it looked like 3 children tested positive for COVID-19 who are vaccinated. Can you please describe those cases, and were there anything that predicted that breakthrough disease?
Yeah. So the 3 cases in the vaccine recipients actually had no comorbidities. They had the onset time after the second dose was somewhere between a month to 32 days to 91 days. The symptoms lasted for 2 to 9 days. However, in these 3 age groups, which is really important, is there were no fevers compared to about 62% of the kids who had a fever in the placebo group. And when we look at the number of symptoms, so in these 3 cases, the symptoms were mild and only 2 symptoms were mainly cough and a sore throat. And when you look at all the placebo cases, more than 50% of the placebo cases actually has 5 or more symptoms. So it seems from the description and the information that we have that clearly the cases in the vaccine recipient group were milder with no fever, and especially when you compare them to the placebo.
Thank you. We'll move on to.
Does that answer your question? Sorry. Yes, it does. Thank you.
Thank you. I think I'm going to ask if the hands that are raised, we have 4 more hands raised, and I'd like to ask if you could just keep it to 1 question each. Dr. Long.
Yes, it's a question about those who were seropositive at the beginning. So now that we know that you looked at the efficacy separately for those who were seropositive at the beginning, and you said I think you said quickly there were no cases in the vaccinated. Were there cases in the placebo group who were seropositive on the day of vaccination? And then the adjacent question is, in those who were seropositive on day one of vaccination, did you see any difference in reactogenicity between those who were seronegative and seropositive? So cases in seropositive placebo recipients first, and then reactogenicity.
Yeah, so I'm going to start with the second part, which is Dr. Long, with the reactogenicity. And as I shown to you, there were very minor differences between those who were SARS-CoV-2 positive and negative, as we have seen in adults, maybe a slight increase after dose one compared to those two. And in terms of cases in seropositive subjects, I believe that we didn't have any, but I'm going to ask Dr. Gruber again just to confirm what I'm saying.
Yeah, so again, Sarah, obviously, I think you're getting at the nature of in this population where those individuals protected. Obviously, it's a relatively small sample, but there were no individuals in seropositive children, either in the vaccine group or the placebo group. And that's why, frankly, the efficacy in terms of documents we submitted to the FDA, when we talk about without prior infection yields an efficacy of 90.7%, and the with and without yields 90.7% because we had no cases in either group.
Okay, and in the approximate number in the placebo group seropositive was what?
The rate was about 8.8% of seropositive in the placebo group.
No, I'm talking about what number was the N for the placebo group who were seropositive who did not get disease in your follow-up period? Sorry. Are we talking about 100 or are we talking about 20?
Yeah, I think perhaps that would be essentially the entire denominator of the placebo group, right? That were seropositive. So what, 10% or so? That'd be about 75 individuals in that group, and in the vaccine group would be about 150. You know, I mean, it may be a little bit less than that, since 8 to 9%, but that gives you a rough ballpark figure.
Okay, that's what I thought. Thank you.
Thank you. And if you could, we're happy to let the team comment after, but I just want to get through these questions because we have to get to the next session. So if our colleagues could just ask one question each, I'm going to go to Dr. Grog, who's been waiting patiently.
Yeah, well, thank you for the presentation, Dr. Gutman. I just had more of a comment than a question, and that is somewhat of a question, how do we explain to our parents that there's only a couple thousand participants in a particular study? And I congratulate you on your further studies, and excited to see what events show in the future, especially with the immunocompromised. So thank you.
Would you like me to address, thank you, the comment about how to explain to parents? I think that probably will be discussed later. I can share with you that actually the study was recruited in record time. Obviously, as I mentioned to you, this was happening during, the Delta variant and, high at the peak probably. We had no problem actually recruiting this age group. And after the FDA requested for us to expand to the new safety group of another, 2,250 kids, we were able to do that in less than 2 weeks. So and the study actually, as I explained and showed to you, number one, we have shown, not only non-inferiority, but actually vaccine efficacy. And I think that with great degree of confidence, we know that this vaccine will be protective. And in terms of safety, the study, as I mentioned, has the 3,000, the N of 3,000 on the vaccine recipients. And obviously with all the activities that will be carried by CDC and by us and other groups in terms of looking at, adverse events following vaccination, will have to come from real data. I will hope personally that the parents are feeling as they felt when they wanted to enroll the kids in the study. But I will leave that to the discussion later today.
Dr. Fink, did you wish to make a comment?
Sure. I just wanted to make sure that it's understood that the safety database size for this age group that supported the emergency use authorization for use of the vaccine in this age group really is at the upper end or even beyond of the safety database size that has supported licensure of other preventive vaccines for infectious diseases for use in pediatrics. And you can add to that the extensive experience that we've had to date with the vaccine in older age groups as well. Thank you.
Thank you, Dr. Fink. Ms. Stinchfield?
Yes, thank you, Dr. Lee. Dr. Gertman, thank you so much for this encouraging data. I have more of a comment on slide 11 related to fever and chills. I was very happy that you emphasized that in this age group, the 5 through 11 or less than 12, that fever and chills is uncommon and certainly less than the 16 to 25-year-olds. And the reason I think that is important to call out is that there are many people who choose to either not get vaccinated or delay vaccine because they frequently will hear either from clinicians or on the media that your common side effects are fever, chills, and body aches. And when you look at the data, that is actually not correct. That the most common, of course, is you see the pain at the injection site, fatigue and headache. And I do think it's important for all of us as we care for kids and families to be evidence-based in what we're asking families to expect. And fever is a very uncommon symptom. So thanks so much for pointing that out.
Thank you. We'll move on to, did you wish to make a comment?
Oh, no. I fully agree with what was said. So thank you.
Thank you. Dr. Freihofer.
Sandra Freihofer, American Medical Association, speaking as a practicing physician. And I'm thinking about the questions that my patients ask me when they come into the office. On slide 10, I think I might have misheard you. My understanding from looking at that is the side effects are less in those that are seropositive. But the big question I wanted to ask was one that was actually brought up at the FDA meeting and alluded to earlier. If a child's 11 years old and they're about to turn 12, should they go ahead and get the 10 microgram dose now or wait until they're 12 and get the 30 microgram dose? Dr. Gruber showed a slide at the FDA meeting, but it was so blurry I couldn't read it. And I would greatly appreciate if you could show that slide so I could, and maybe I could take a look at the data. Thank you.
Thank you. Before you respond, I just, we discussed what the trial contained. I don't know if Dr. Fink, I'm going to put you on the spot, apologies, could just make a brief comment about what FDA has authorized based on the trial data.
Sure. So what FDA has authorized is that either the 10 microgram formulation that is authorized for use in ages 5 through 11, or a 30 microgram formulation that is authorized for use in ages 12 and above can be used for either dose 1 or dose 2 in the situation where a child will be 11 years old when they are set to receive dose 1 and then turns 12 before they are set to receive dose 2. Of course, the most data-driven approach, the approach for which the data are actually available, would be for a 10 microgram dose be given to a child who is 11 at the time the dose is administered, and for a 30 microgram dose to be given to a child who is 12 at the time that dose is administered. However, FDA did recognize that there may be some situations in which there would be a need for flexibility, and the totality of data did support this more flexible approach where there would be a change in age occurring in between the two doses. And it's up to CDC to make, an ACIP to make whatever they consider to be the most appropriate recommendations for implementation of the doses such as they're authorized.
Thank you, Dr. Fink. And Dr. Freihofer, there will be... Oh, Dr. Freihofer, just one moment. There will be a whole discussion and presentation specific to this issue later this afternoon in the clinical considerations. Would it be okay in the interest of time if we come back to your question in the afternoon when we can have a more full presentation?
Sure. And would they be able to show that slide with the data?
This slide 25 that's up here now?
No, there was a slide that they showed that Dr. Gruber showed at FDA that addressed that question, that compared the neutralizing titers at age 11 to those with getting a 10 microgram dose, with those at age 12 to 15 getting a 30 microgram dose. That's the slide.
So I Dr. Lee, if that's okay, I have that slide, but the one in the backups,
Which slide number is it?
Hold on a second, maybe. Go to my own.
If need be, we can always come back to this later in a later session, just in the interest of time. I will put this on our question list to come back to perhaps ask Pfizer to respond to if need be. But why don't we go to the last question, which is Dr. Kane, while you're trying to identify that slide.
May I comment just, even if we don't have the slide, and I'm happy to refer to this later. That slide actually that Dr. Gruber showed it reflects the phase 1 part of the study where we did compare the younger kids to the 16 to 25 as well as the 12 to 15. And I'm happy to point that to you later so you can show it in the afternoon.
Thank you. And it's also available on the FDA website. So in the meantime, let's go to Dr. Kane, who has the last question for this session, and then we will take a break. Dr. Kane. Dr. Kane and then Dr. Sanchez, and then we'll take a break. Dr. Kane, we can't hear you. You're still muted. Okay. We'll move on to Dr. Sanchez.
Thanks, Grace. I just have a quick question. I assume that no concomitant vaccinations were given to these children. What was the time period? And are you planning studies looking at concomitant vaccines in these age groups? Thank you.
Thank you for the question. Yeah, so no concomitant vaccines were administered during the study. It was a temporary delay criteria if somebody received one. We are considering doing some concomitant vaccine studies, although CDC now has a recommendation that vaccines can be given at the same time. So at the present time, we don't have any additional data in this age group for concomitant administration of this vaccine with others.
Okay, thank you. Dr. Kane?
So yes, I maybe should wait for this question for later, but I was concerned about because we have such a high rate of obesity in African Americans, the question has to be that if I'm getting close to the 12 years of age because of the high rate of obesity, should I be waiting to wait till I get to 12 years in order to get the larger dose where I may have a much more prolonged and higher rate of geometric mean titer because of that significant overweight that I'm sure it's greater than 30% in our African American children?
This is Dr. Oliver.
We also have significant comorbidities associated with as well. It's like a double whammy.
Yeah, this is Dr. Oliver. I just want to highlight that we will be having a presentation this afternoon on the clinical considerations that will get into, proposed.
I will wait for that this afternoon and bring it up again. Thank you.
Okay, promise. Thank you. Just wanted to make sure people were aware. We'll have this where we'll address kind of these variety of scenarios and propose CDC guidance. Thanks.
Thank you. And so if you didn't get your question answered, I promise we will offer opportunity for questions later in the day. Right now, I would like for the committee to take a break. Let's take a break till 30 minutes after the hour. Thanks, everyone. We'll recess.